In 2018, the woman running Medicare declared war on a machine. Seema Verma told America's doctors to get rid of their fax machines. Gone, she said, by 2020. It was a good goal. And it missed. The 2020 deadline came and went, and the fax machines never left. Because years earlier, the federal government had spent something like $35 billion putting an electronic health record into nearly every hospital and doctor's office in the country. And somehow, after all that money and all those computers, the fastest, most reliable way to move your medical records from one of them to another is still to print them out and feed them into a fax machine. In the age of the smartphone, American medicine runs on 1980s technology. Why? For the finale, let's follow the paper trail one last time. Here's the paradox in one breath. We digitized American medicine. Nearly every hospital and physician now runs on an electronic health record. And yet those record systems still can't reliably send information to each other. So when your specialist needs the file your primary care doctor is holding, the 21st century answer is often to hit print and send it over a phone line. The fax machine didn't survive because healthcare is backward or lazy. It survived because it's the one tool that works when two multi-million-dollar computer systems refuse to speak. Fax isn't the disease, it's the symptom and the workaround for a system that can't talk to itself. Let's see how that happened and why the fax is so hard to kill. Let's answer it like an operator. Why, after a historic investment in health technology, does American medicine still lean on the fax? The story runs through a law that paid for the wrong thing, a set of software companies with every reason to build walls, and a fax machine that turns out to be a shockingly rational choice. And to be clear up front, this isn't a tale of pure failure. A lot went right. The honest version holds a real success and a real failure at the same time. Let's follow the paper trail. Start with the money and the win, because there was a real one. In 2009, in the depths of the financial crisis, Congress passed a law called HITECH that did one simple thing. It paid doctors and hospitals to adopt electronic health records. And it worked spectacularly at that job. In 2008, fewer than 1 in 10 American hospitals had even a basic electronic record. 7 years later, it was about 84%, a nearly 9-fold jump. And among office doctors, adoption climbed from around 4 in 10 to more than 9 in 10. Roughly $35 billion federal dollars turned a paper industry digital in under a decade. That is not a failure, hold on to it, because the failure is about to land right next to it. Now the failure, buying every hospital a computer is not the same as getting the computers to talk. Federal researchers measure interoperability across 4 abilities. Can a hospital find outside records, send them, receive them, and, the hard one, integrate them into the chart without a human retyping everything? As of 2023, about 7 in 10 hospitals engaged in all 4, at least sometimes, but only about 43% did all 4 routinely. The rest managed it only occasionally or not at all. And getting the data to arrive is only half the battle. Even among hospitals that can pull in outside records, only around 4 in 10 have clinicians who routinely use that outside data because it doesn't slot cleanly into their workflow. We digitized the record. We never digitized the handoff. So how did we spend $35 billion and skip the most important part? The law paid for adoption, but not for exchange. Its rules, called meaningful use, rewarded doctors for using an electronic record. E-prescribing, recording vitals, checking boxes. They barely rewarded sending data to the hospital across town. Providers got paid whether or not their system could talk to anyone else's. On top of that, in the early years there was no single enforced standard for how records should be formatted, so certified systems could meet the letter of the rules while remaining mutually unintelligible. And the software market consolidated around a few giants, Epic and Cerner, now owned by Oracle, for whom seamless data sharing inside their own ecosystem was a selling point, and frictionless sharing with a rival system was simply not good business. We built islands of excellent connectivity, separated by moats. Break interoperability into its parts and you can see where it thins out. Sending a record, most hospitals can, About 92%. Receiving one? 87. Finding an outside record when you need it? Around 82. But integrating that record into your own chart, pulling it in as usable data without a human retyping it, only about 78% can, and far fewer do it smoothly. Integration lags, but notice the real cliff isn't any single column, it's doing all four together routinely, which, as we just saw, only about 43% of hospitals actually manage. And a gap like that is exactly where a workaround takes hold. When the systems can't cleanly absorb each other's data, someone prints it and faxes it, because at least a fax always arrives. Here's the part that surprises people. The fax is not a dumb choice, and to be precise, much of today's fax isn't a beige machine with thermal paper at all. It's electronic, cloud-based fax, sent and received as a digital file. But the logic is identical, and every advantage that follows holds either way. It's a rational response to a broken environment, and it has real advantages. First, it's universal. Every provider, pharmacy, nursing home, and one doctor rural clinic has a fax number. You don't need to know what software the other side runs, or whether they've ever heard of the modern data standards. A fax number works for everyone, with no setup. Second, it's legally comfortable. Faxing protected health information is a long-accepted, HIPAA-friendly channel, and the compliance officers know its rules cold. And third, it's gloriously simple, point to point. It works across completely incompatible systems. When your Epic and their Cerner can't agree on a format, a PDF over a phone line sidesteps the entire problem. Two more reasons, and the last one is the quiet killer. Fourth, the fax gives you a paper trail, a confirmation page that says sent, received, time-stamped. In a liability-heavy, audit-obsessed industry, a tangible receipt is reassuring in a way that a silent, did-it-land data transfer is not. And fifth, the one that really keeps it alive, the fax requires no integration project and, crucially, nothing from the other side except a working number. Real interoperability is a two-sided effort. Both parties have to adopt the standards, build the connection, and maintain it. A fax needs your counterpart to do exactly nothing. In a fragmented system with millions of small players, the tool that demands nothing of the other side will always beat the tool that demands everything. How common is it really? Honest answer, nobody has a clean government census. The eye-popping fax numbers you see tend to come from fax vendors, so treat them with a raised eyebrow. But even the labeled estimates are striking. One 2019 survey from a messaging vendor, small sample, so weigh it accordingly, found about 89% of healthcare organizations still using fax and nearly 40% still using pagers. Is it 1970, the survey asked, or 2019? The exact percentage is fuzzy, the direction is not. A decade after we digitized medicine, the fax and the pager were still doing the heavy lifting. It is finally getting better. The scaffolding for a fix is going up. In 2016, Congress passed the 21st Century Cures Act and did something high-tech never had. It made deliberately blocking data sharing illegal, with penalties up to $1 million per violation for the tech companies and networks that do it. There's now a modern, web-style data standard. It's called FHIR, baked into federal certification, so systems finally have a common language to speak. And at the end of 2023, a national framework called TEFCA went live, stitching the existing regional networks into a network of networks. The plumbing for nationwide exchange, at long last, exists. But notice the timing. TEFCA turned on in December 2023, and the official running it called it, with a straight face, the Big Bang. A Big Bang 14 years and $35 billion after we started. That quote is optimism, and the optimism is real. The framework genuinely matters. But it quietly admits how long a single, unified national framework took to build. Years after private networks like Quality and Commonwealth were already moving records. 14 years to build the official on-ramp, and there's an irony worth savoring. Some of the same software giants whose walled gardens made sharing so hard are now wired into the national network built to bridge them. Epic runs one of its official hubs, and the incumbent networks the other big vendors belong to are joining in too. The gatekeepers became the bridge keepers. So here's the honest scorecard, because the finale of this series should refuse to pick an easy side. High-tech's $35 billion was a genuine success. It dragged a paper industry into the digital age in under a decade. It was also a genuine failure. It paid for the computers and forgot to make them share. And the story isn't standing still. The share of hospitals doing all four kinds of exchange, at least sometimes, climbed from 46% in 2018 to 70% in 2023. Even as routine, all four use still sat near 43%. This is not nothing worked. It's slower and shallower than promised. And in the gap between the promise and the reality, for now, sits the fax machine, quietly holding the whole thing together. So here's the whole thing, and the whole series, really, on one last card. 1. We spent $35 billion and successfully put a computer in nearly every hospital. 2. We forgot to require that those computers share, so they didn't. 3. Into that gap stepped the fax machine, universal, legal, simple, and demanding nothing of anyone. The perfectly rational workaround for a system that can't talk to itself. And 4. The real fix, 14 years late, is finally arriving. The fax was never the disease. It was the symptom, the clearest possible sign of a health system that spent a fortune on technology and skipped the part where it all connects. If you take one thing from this finale, make it this. The fax machine isn't a punchline about a backward industry. It's the neatest summary of everything we've explored. A system that spends staggering sums, optimizes for the wrong things, builds walls where it needs bridges, and leaves the people at the bedside to improvise the workaround. The fax survives because it solves a problem the $35 billion plan was supposed to solve, and didn't. Fix the connection, and the fax retires on its own. Until then, every time one hums to life in a hospital back office, it's telling you exactly where the system still doesn't work. And that's where we'll leave it. Over this series, we've pulled the system apart one piece at a time. Why an ER visit costs a fortune. Why hospitals are always full. What your insurer and your PBM actually do. How hospitals really make money. Why they keep merging and buying up your doctor. Why the people inside are burning out, and why, after all of it, the whole thing still runs on a fax machine. If there's a single thread, it's this. Almost nothing in American healthcare is the way it is by accident. It's the product of incentives, rules, and history, which means it can be understood, and what can be understood can be changed. Thank you for following the money and the paperwork all the way through. For everything we've covered, visit shanewelter.com. Take care of yourselves, and I'll see you out there.